Hello guys, welcome back to my channel. In today's video, we're going to compare and contrast the different opioid use in anesthesia, and our point of reference is going to be morphine. So we're going to be diving into morphine and meperidine, fentanyl, alfentanyl, remifentanil, sulfentanyl. So let's start with their origin. Morphine is a naturally derived opioid, while meperidine, fentanyl, sulfentanyl, alfentanyl, remifentanil, all these opioids are synthetic opioid derived from phenylpiperidine. And they kind of, because they are synthetic, they have kind of different chemistry or properties that we're going to review later. So mechanism of action, they all have the same mechanism of action. Opioid are G protein receptors. So how do they work? When you administer opioid, they go and bind to the different receptor that are in the body. So in the CNS, they're going to bind in the presynapse and postsynaptic part of the neurons. So in the presynaptic, they're going to bind and inhibit the calcium channels. So by inhibiting the calcium channel, they inhibit the release of the neurotransmitter at the origin of pain. So they're going to inhibit the release of substance P. They're going to really inhibit the release of glutamate, acetylcholine, norepinephrine, dopamine, all these receptors that causes pain from the spinal thalamic tract. And on the postsynaptic receptors, they're gonna enhance the entry of potassium inside the neuron. That is gonna hyperpolarize the membrane, making the membrane more negative inside, and that's how they're gonna exert in the CNS. In the spinal cord, they're gonna act onto the dorsal ganglia both into the lamina too, and acting there, they're going to act in the substantia gelatinosa and modulate the response to pain. And and they also have different receptors at the periphery, but we are not going to dive into all these receptors because they can be a lot. So morphine, they have also what they call endogenous peptide. So all these opioids, so we have like mu receptors that are going to bind to endorphins. We have kappa receptors that are going to bind to dynorphins. We have delta and cofalins. So it's good to point that all the opioid, including morphine and the synthetic, have a high affinity for mu, except for meperidine. Meperidine is going to bind more to kappa receptors. That's why it's only going to help with like moderate pain. And also meperidine is kind of special opioid because it's the only opioid that is going to give you mydriasis, so, and also gonna give you tachycardia because its structure is related to atropine, and atropine is an antimuscarinic anticholinergic, so does things opposite to acetylcholine. So that's why in meperidine, you're gonna have these mydriasis and tachycardia and only moderate pain. Now, talking about the mu receptors, this is where our opioid synthetic and natural derived like morphine has the highest affinity. So we have mu1 and mu2. Mu1 is responsible for things like bradycardia, responsible for urinary retention, while mu2 is mainly responsible for the physical dependence property of opioid, responsible for hypoventilation, and it's also responsible for decreasing your GI motility. So we have mu2 is basically spinal, while mu1 is can give you a supraspinal pain modulation. and this is also very important to note. So for meperidine, we say it binds to kappa receptors, and instead of giving you that urinary retention that you see with the mu1 receptors, meperidine is going to promote diuresis because it's going to inhibit vasopressin. Vasopressin, or antidiuretic hormone, is the hormone responsible of retaining the water through the kidneys. But binding to kappa receptors, meperidine is going to inhibit that hormone, so you're going to have diuresis, which is also something that is different from other opioid with meperidine. So now let's talk about their potency. So how potent, how can we classify them? So sulfentanyl is going to be the more potent because it's going to be 5,000 to 10,000 times more potent than morphine. After sulfentanyl is going to come fentanyl and remifentanil. They have about the same potency, and they're going to be 100 times more potent than morphine. After that is alfentanil, which is going to be 10 to 20 times more potent than morphine. And then comes morphine, and then meperidine comes last because it's going to be like 1/10 the potency of morphine. So sulfentanyl is more potent than all. Now, amnesia, all these opioid, morphine and the synthetic, they don't cause you amnesia. This medicine are very particular because they give you that pain control without affecting your sense of proprioception, touch, or consciousness. So you don't get to forget things with these opioid. Now let's dive into their pharmacokinetic. So effect site equilibration, we're going to talk about the time that it takes from the moment the medication reaches the blood through to get in the brain. Remember, the brain is our target. We want our medicine to reach in the brain. So how long it takes to this drug to get into the brain. Morphine has a slow onset, a slow effect site equilibration. It gets to the brain slowly, mainly because it's not that liposoluble like other synthetic. Morphine is liposoluble but less than others. Fentanyl is going to take you about 6.8 minutes. So fentanyl is going to take you 6.2 minutes. And then when you come to alfentanil and remifentanil, they're going to get there quick, 1.4 minutes, and you're going to have the onset of your action. So if you want something quick to go, quick onset, like if you have laryngoscopy or retrobulbar block, you want to use alfentanil or remifentanil. Now let's talk about their continuous infusion half time. This is not that important because for anesthesia provider, you want to know the context sensitivity half time. Continuous infusion half time just tell you how long it's going to take for 50% of your drug that you're giving in continuous IV to be eliminated, but you don't take in consideration the time. So if we just quickly take a look at their continuous infusion half time, remifentanil is going to be quick. It's going to be the one that is going to be quickly removed, then alfentanil, then morphine, then sulfentanyl, then meperidine, and then fentanyl. Now, if we look at their context sensitivity half time, the time that it takes for 50% of the drug to be eliminated from the body after a specific infusion of a specific duration of action, we're going to see that after 2 hours, fentanyl context sensitivity infusion, context sensitivity half time is going to be greater than sulfentanyl because fentanyl loves the tissue. It has a large volume of distribution. So after it gets to the brain and does whatever it wants to do, he loves going into the skeletal muscle and the fat and stick there. So it's going to take longer for it to be eliminated. Now, if you look at sulfentanyl as compared to arfentanyl. For infusion greater than 8 hours, actually sulfentanyl is better because its context sensitivity half-time is going to be low. So if you want to give an opioid with long duration of action for longer procedure, you can use sulfentanyl. Arfentanyl is great because after 10 hours, its context sensitivity half-time is not going to be keep accumulating. It's going to plateau at one point. But this drug is a great drug if you want to use it for a surgery that need a quick onset of action to neutralize the pain, but it's not that great for longer procedure. I would go with sulfentanyl. And now remifentanil has the best profile. It does not accumulate, it stays plateau, and we're going to see why. It's because of its metabolism. So talking about their volume of distribution, morphine has a small volume of distribution. Fentanyl and sulfentanyl, they have large volume of distribution. And because they have large volume of distribution, the termination of their action is going to be mainly through redistribution, because they're going to move from the vessel-rich group, which is the brain, heart, lungs, and redistribute to the medium, like liver, skeletal muscle, and then go to the low vessel preferred group. So these two, sulfentanyl and fentanyl, they're going to terminate their action through redistribution. Alfentanyl have a low volume of distribution, 4 to 6 times less than what we have with fentanyl, and remifentanil also has a low volume of distribution. These drugs are not going to accumulate that much in the peripheral tissue like we see in fentanyl and sulfentanyl. Now let's talk about the peak of action. So if you give morphine IV, it's going to take 15 to 30 minutes to see the peak of action. But if you give fentanyl, it's going to take 5 to 10 minutes. And if you give sulfentanyl, it's even faster, 2 minutes, and you see the peak of your action. And when you give IM morphine, it's going to take 45 to 90 minutes for you to see the peak of action. If you give morphine CS through the CSF, like let's say you give intrathecal morphine, it's gonna take 1 to 4 hours to see the peak. So that's a long time, and this is the reason why morphine is gonna be responsible of giving you that late respiratory depression, because it peaks up to 4 hours in the CSF, and you will not see that in fentanyl, because in the CSF, fentanyl is going to peak at about 20 minutes, and sulfentanyl is even faster in the CSF. It's going to peak up at 6 minutes. So let's talk about the duration of action. So if you give a single dose, fentanyl has a shorter duration of action than morphine for a single dose. But if you want to give them as continuous infusion, because fentanyl love other tissues, it's going to give you a higher duration of action than morphine. And like we say, sulfentanyl is great for longer procedures. Arfentanyl is great if you want a quicker onset of your pain, procedure that require like a quick neutralization of pain. And remifentanil is great if you want a long procedure that you want to be able to remove your patient from analgesia quick, because it's not going to accumulate. The moment you turn off that infusion, you have up to 10 minutes to have that patient in pain again. And that's why with remifentanil, a lot of providers will use a rescue narcotic, something to alleviate the pain, because after you turn off that infusion, or if you lose your IV, it's not going to take long for your patient to feel pain. Now let's talk about their metabolism. Morphine, we have a good past hepatic effect. So this is why the dose of morphine IV is different from the dose pills. Like if you give 4 milligram pill is the equivalent of 1 milligram IV with morphine. Fentanyl, we have a first lung pass effect up to 75% is going to be picked up by the lung. Same with sulfentanyl. Sulfentanyl is also going to have a lung pass effect. So let's talk about their metabolism. Morphine is intensively metabolized both by the liver and renal. So if your patient has a end stage renal failure, you don't want to give morphine unless you really have to. Morphine is also going to be metabolized into an active metabolite, morphine 6-glucuronide, and this active metabolite is more potent than morphine, and it even has a longer duration of action than morphine. And if we talk about meperidine also has an active metabolite, which is normeperidine. And if your patient have a renal failure, that normeperidine can accumulate and give you seizures. So just pay attention. And morphine also is eliminated renally, less than 3% on change in the kidneys. Now let's talk about drugs like monoamine oxidase inhibitors like seleginate, phenelzine. So these drugs, because they inhibit the monoamine oxidase enzyme, they're gonna inhibit the glucuronidation of morphine and meperidine. And it's actually a real case of a patient that were given meperidine with monoamine oxidase inhibitors that cause serotonin syndrome. So you don't want to mix monoamine oxidase inhibitor with meperidine. Is a no-no. Now, fentanyl is metabolized by the liver, and it doesn't have an active metabolite. And like we said before, the termination of action of fentanyl is due to the redistribution. Sulfentanyl is very high protein bound, about 98%, and is bind to alpha-1 glycoprotein. Alpha-1 glycoprotein mostly bind to base, while albumin binds to acid. So this alpha-1 glycoprotein is low in neonates. So if you have a neonate, you really want to go down on the dose of sulfentanyl, because if sulfentanyl can bind to that alpha-1, it stays in the blood and give you greater effects. Alfentanyl also has a high protein binding, up to 96%, and is metabolized in the liver by the CYP453A. So if you have those drugs, CYP450 enzyme inducer or inhibitor, they can affect alfentanyl metabolism. And also midazolam go through the same pathway. And remifentanil is the special opioid that is not affected by renal metabolism and liver metabolism, and is greatly and extensively metabolized by the non-specific esterase enzyme in the plasma. And this is why it does not accumulate at the it starts fast. The onset is 1.4 minutes, and it's also end up its action very fast. Now, for the histamine release, morphine and meperidine are responsible of releasing histamine that is going to give you bronchoconstriction, hypotension, and vasodilation of your veins. Fentanyl and sulfentanyl will not do that. Now let's talk about ventilatory depression. Morphine is going to give you a dose-dependent ventilatory depression, and it's going to shift your CO2 curve to the right. What do I mean by CO2 curve to the right? That means that you require higher CO2 level to stimulate breathing. So normally our body require is when the CO2 reach a certain point that it triggers the breathing. But with morphine, you need to go even higher on that CO2 to see your patient breathing. And meperidine does that even more than morphine. So don't forget, morphine is going to give you that late respiratory depression in the CSF because it's not liposoluble. It floats in the CSF, and it's going to peak in about 1 to 4 hours in the CSF. You are not going to see that late respiratory depression with fentanyl in the CSF. If you have a patient who has hypercardia, so if the patient has increased CO2 level, it's going to increase the blood flow into the brain, and it's going to promote the uptake of morphine into the brain, giving you more effect. And if you have a patient who is hyperventilating, losing the CO2 is also going to promote the morphine to be in the unionized form, which is going to help also cross the CSF and get to the brain easily and give you more effect. Morphine also can give you cough suppression, but codeine is going to give that more than morphine. And also you're going to have bronchoconstriction because of the histamine release, and decrease the ciliary activity in the lung with morphine. With fentanyl, because it loves all the tissue and fat, it's gonna give you two respiratory depression peak. The first one is gonna be when you have that high fentanyl in the blood, and then after the redistribution, fentanyl is going to go into the other tissue, accumulating into the gastric mucosa. When it's going to get trapped there because of the acidity and base in alkaline, it can be unionized to cross the membrane. So it's going to get trapped into your gastric mucosa and also the first lung pass. And by the time it goes back into your blood, inactively, is going to give you that other respiratory depression. With sulfentanyl, you have less respiratory depression, but you can get laryngospasm. Now, all these opioids are contraindicated in patients with head injury that are not mechanically ventilated, because they have these patients that are not mechanically ventilated, their CO2 is going to accumulate, increasing their cerebral blood flow and increase their ICP, which we don't want in patient with head trauma. So if you have your patient with head trauma, make sure they are mechanically ventilated before you administer them opioid. Sulfentanyl and fentanyl, even if the patient is mechanically ventilated, it's going to affect the autoregulation in your brain. So it's going to increase your ICP, decrease your MAP, and increase your cerebral blood pressure. This is why we say they have that autoregulation. They affect the autoregulation in your CNS. Now let's talk about the effects on the heart. So all these opioids are cardiovascular depressor. Morphine is going to be indirectly acting, depressing the sympathetic nervous system to decrease your heart rate and other hemodynamic component, but it's also going to act on the vagal action in the SC node and AV node to give you that bradycardia. And with the release of histamine, morphine is also going to give you a low blood pressure. Fentanyl is going to give you more bradycardia than morphine, and sulfentanyl is going to even give you more bradycardia. But with remifentanil, you can have a mild decrease in your blood pressure and your heart rate. So these drugs are going to act indirectly, depressing your sympathetic nervous system. So lowering this hemodynamic effect, lower your heart rate, your blood pressure, and the rest. Now let's talk about biliary spasm. Biliary spasm, this opioid also are at the origin of biliary spasm. Fentanyl more than morphine, more than meperidine, and more than pentazocine. Pentazocine is agonist antagonist at morphine receptors. I'm not going to talk about it today, but it's important because if your patient is going to do a surgery, laparocholecystectomy, and the surgeon is observing the presence of spasm, if you have given this opioid, like let's say morphine, they can actually stimulate the spasm and put a false positive in the eyes of the surgeon. So you don't want to do that. Also, these opioid is gonna cause nausea and vomiting in your patient. They do that by three main mechanisms. They have a direct stimulation on the chemoreceptor trigger zone located at the floor on the fourth ventricle. By stimulating this receptor directly, they promote the sensation of nausea and vomiting. They also has a partial agonism at dopamine release. We know that the drug that responsible of decreasing nausea and vomiting are dopamine antagonists. So this drug have a partial agonism at dopamine at the chemoreceptor trigger zone. And also morphine is going to add to all that. It's going to slow your gut motility through the mu2 receptors. So this is why you really want to pay attention to your risk of aspiration when you give all these opioids. Now, when we look at the placenta, if you have a pregnant lady and you want to give an epidural, we don't advise medicine like fentanyl because of the long contact sensitivity half-time, and all this opioid also can pass through the placenta, even morphine, and give a greater respiratory depression to the neonate, to the baby, and even the dependent. So we want to give opioid after the baby is born. So the tolerance, we can have a cross tolerance among all the opioid, and this is due to mu2 receptor, and the tolerance will not affect meiosis and constipation. So if your patient is taking morphine, it's not going to be tolerant to meiosis, that constriction in the pupil, and also constipation. So intolerance can occur without physical dependence, meaning that you can have to increase the doses of your morphine without your patient being physically dependent. Now let's talk about the interactions with other drugs. So like fentanyl, if you give fentanyl with midazolam or propofol, you're gonna have synergistic effect. It's gonna give you synergistic effect in the ventilatory depression. So we don't want to do that. And also, if you give opioid with nitrous oxide, our gas, and you're gonna have a greater myocardial depression that none of them really does if you give them separately. So you want to take an eye on that. You want to be cautious when you administer opioid, morphine, or fentanyl to patients with Parkinson's disease, because fentanyl is going to decrease the dopamine release, while morphine is going to be an agonist at the chemoreceptor trigger zone to promote nausea and vomiting. And we know that Parkinson, they have less dopamine, so all this interaction with dopamine, you really want to be cautious when you administer that with a patient with Parkinson's disease. You also want to make sure that when you give your opioid with any benzodiazepine, you know that you can have a profound respiratory depression. So these are mainly the characteristic I was trying to compare between all these opioids that we are administering. If you like this video, please thumbs up. Don't forget to click the notification bell and subscribe to my channel, and I will see you on my next videos. Thank you.